Right.
Okay, hello everyone, and welcome to the UC Irvine Age-Friendly Geriatric Education Tele-ECHO series on mental health. This is our third session. I'm really happy you all can join us today, and I hope you all are doing well. We'll go ahead and get started. This specific session in our mental health series will be focusing on insomnia in older adults, and today's objectives are identifying issues which contribute to problems with sleep in older adults, reviewing basic sleep architecture, review sleep hygiene as an option for managing insomnia, and reviewing medications, new and old, which are used for insomnia. Today's target audience is you all, MDs, DOs, NPs, PAs, and really any other healthcare professionals with an interest in the care of older adults. As mentioned in prior sessions, we are accredited by the ACCME and to provide continuing medical education credit for physicians. And CME credits are also recognized by the CBRN because they do recognize CME credits as well as transferable. After the series, you will receive a health professional certificate or a CME certificate, and you will receive an email in order to fill out the form to receive those credits. Today's agenda is as follows, with welcome and announcement and introductions, followed by a didactic presentation, which will be on insomnia in older adults, followed by a patient case and discussion, and then closing and reminders. Just some house rules. Please be sure to mute yourself when you're not speaking to prevent background noise. If you can, try to introduce yourself prior to speaking with your name and location, and always maintain confidentiality when speaking about the patient case. This session is being recorded. And just to let you know, this project is supported by the Health Resources and Services Administration, and information or content and conclusion are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the US government. Our faculty do not have any financial disclosures at this time. And as we do in all of our sessions, we do want to get to know you all. Since we have quite a few in the room, we'd love for you to go ahead and introduce yourself via the chat function with your name, your role, your site, and location. And then our hub team will go ahead and introduce themselves. My name is Nika Seville. I'm the project manager for our Geriatric Workforce Enhancement Program here at UC Irvine, when we're located in Orange County, California. So go ahead, other members of our hub team, please introduce yourself.
Well, I'll go. So Lisa Gibbs, I'm Chief of Geriatrics at UC Irvine, and we are thrilled to see you all here. Thank you.
I'm Sonia Sagal, geriatrician at UC Irvine. Welcome, everybody.
Tanya Gurbich, clinical pharmacist. I am at UCI Senior Health Center and teach at USC Pharmacy School.
Camille Fitzpatrick, geriatric nurse practitioner, working at the Santa Ana Family Health Center, teaching family medicine residents and nurse practitioners. Welcome.
Hi, everyone. Welcome. My name is Carlos Garcia, and I'm the web data analyst.
Hi, I'm Fazia Asif, and I work here at St. Joseph in Tustin as a primary care and also a geriatric medicine. Yeah, I did my fellowship from UCI, and it's really nice to see Dr. Sagal and Dr. Gibbs, my preceptors.
It's great to have you, Fazia. That's wonderful. Thank you.
Very nice to see you.
Yes.
Thank you.
Wonderful to have you. And do we have any of our other, I do
Yes,
see some on in the chat.
Yeah, Dr. Hubi, how are you?
Hi, Dr. Hubi. Nice to see you again.
Nice to meet you. How are you doing? Yeah, I'm family
Good, thank
physician in
you.
Calgary, Alberta, Canada.
Wonderful to have you.
Thanks.
And thank you all. Okay, we'll go ahead and move on to our presentation today, our didactic presentation. Today's session is going to be led by Dr. Gurbich, and she's an assistant professor of clinical pharmacy at USC School of Pharmacy, as well as an adjunct professor of family medicine here at UCI Medical Center. So go ahead, Dr. Gurbich.
Okay, thank you for having me. So today we're going to talk about some, let me move you the screen out of the way. We're going to identify some issues which contribute to problems with sleep in older adults through basic sleep architecture, a little bit on sleep hygiene, and review some medications, new and old, that are available for the treatment of insomnia. Next. So just a brief overview. So insomnia is a really common problem in the general population, affecting up to 20% of those individuals. But in the older adult group, it's even more common. Almost 60% of patients over the age of 65 have insomnia, and it comes at a great cost from the medical and financial standpoint. Obviously, consequences of insomnia include daytime dysfunction, decreased quality of life, psychiatric disorders, and things like that. Next slide. So what are some of the age-related changes that happen with sleep? Overall, there's a decline in sleep quality and duration. There's also decreased sleep efficiency. So the depth of sleep we get changes, the intensity and the continuity also decreases. There's a weaker circadian regulation, and we see that a lot in our very old patients and those with dementia, especially, where they get night and day mixed up a little bit and sleep mostly during the day and are up and around at night. Most of the time, older patients experience more frequent awakenings throughout the night. That's kind of a normal age-related change. They do experience early morning awakenings, and to a lesser extent, they have trouble falling asleep. Next slide. Okay, so let's review really briefly the normal stages of sleep. Stage 1, this is mental relaxation, your eyes closing and kind of getting ready to sleep. It takes about 5 to 30 minutes in that stage. And then stage 2 is generally less deep. You disconnect from the outside world, can't hear the noise, and that typically makes up about 50% of your time. And then you go into the deeper stages of sleep, which is delta sleep, stage 3 and 4 sleep. And so that's the really restorative deep sleep that's really helpful for improvement of daytime functioning. And then there's a REM sleep, which is the dreaming part of sleep. Next slide. So when you look at changes with aging, you really see a significant difference. In a younger patients spend a lot more time in deep sleep and REM sleep compared to their older counterparts. So with age, it takes, stage 1 extends, it takes a little bit longer to fall asleep. Stage 2, this is the sleep that you're generally awakened from, is impaired in an older adult. So they do experience a lot of awakenings throughout the night. Sleep 3 and 4 shrinks, so we spend less time in deep sleep as we age. That's a normal age-related change. And then the REM cycle becomes shorter as we age as well. So there's a significant number of differences that happen just as a normal part of aging, and that's one of the reasons a lot of older patients have insomnia. Next slide. So how do hypnotics affect the sleep cycle? Unfortunately, they affect it in the wrong direction in a lot of ways. So sleep stage 1 is shortened, so it takes less time to fall asleep. So most of these agents will allow you to fall asleep faster. But what they mostly do is extend stage 2. So extend the less deep sleep that is shortened in an older adult. But when it comes to stage 3 and 4, they that older adults who take these medications end up sleeping in deep sleep or delta sleep less time. And then it also shortens REM, so you dream less. So a lot of times you'll get REM rebound after you've been on a hypnotic for a long time and have discontinued it. And often older patients will complain of really vivid dreams or even nightmares associated with that discontinuation. Next slide. So there's a really good study that was published a while ago now in 2006 that looked at 23 randomized trials of cognitive behavioral treatment, relaxation, and other behavioral therapies to manage sleep. And they found that this non-pharmacologic approach is much more effective than the drugs that we use to treat it. They do all the right things. They improve sleep onset, they improve sleep efficiency, sleep quality, and really do a lot more good than any of the drugs that I'm going to talk about in the next several slides. Next slide. So I know physicians typically don't have time to spend a lot of time on sleep hygiene with patients, but then this is your opportunity to get other professionals involved. Occupational therapy, this is what they do for a living. One of the things they do is discuss sleep hygiene with patients and figure out how they can change things. In my clinic, a lot of times I get these referrals from the physicians, and I will actually spend an appointment talking about their sleep cycle, what they do during the day, and what can be done to improve it. So these are some things on the slide that are listed, are some of the things that you want to talk to them about when it comes to managing sleep non-pharmacologically with improved sleep hygiene. I can tell you from my experience, every time I talk to any person about insomnia, as I go through this list, I will find at least something that they're doing that's strange, that can potentially contribute. Some people exercise really late at night. Some people drink a lot of alcohol or caffeine, or even just water at night, so they're up a lot peeing. Sometimes they take their medications in funny ways that contribute to nighttime awakening. So there's lots of things you can do to fix the insomnia issue without adding more sleep meds. Next slide. So this is just a slide showing some caffeine content that, you know, may not realize how much caffeine is in some of these products, like a Starbucks grande coffee is 320 milligrams. To give you sort of a comparison, a caffeine pill like No-Dose, for example, or Vivarin that's available over the counter is 200 milligrams. If you've ever taken that, you know that that sort of gets you going for really well for a number of hours. So 320 milligrams of caffeine in a cup of coffee is a huge amount. But even things like Ben & Jerry's coffee ice cream have 84 milligrams. Mountain Dew, which most people don't think has caffeine at all, also has some caffeine in it. So really getting a dietary history is also important to figure out why there's a sleep issue. Next slide. So I'm a pharmacist, so I'm going to focus on meds. These are some of the medications that can potentially contribute to insomnia. I just saw somebody yesterday in my assessment clinic at USC. This patient was on Lasix twice a day, 40 and 80 milligrams. He was taking 80 milligrams at bedtime. And guess what? He was waking up 5 times a day to pee. So going through the med list and figuring out when they take it is super important. So dopamine agonists can contribute. Some antidepressants like Wellbutrin is very activating, as well as fluoxetine can contribute to insomnia. Overcorrection or undercorrection of thyroid could contribute to insomnia. HRT has been associated with it. Herbal supplements with any kind of stimulants in it can do it. Certain antipsychotics, dementia medications can worsen sleep. Steroids can either kind of put you to sleep or get you really hyper. Decongestants that are often available over the counter. Most patients don't even realize they're taking one, like Claritin Ds or Teg D. All of them have phenylephrine in them. So that can contribute. Beta agonists, especially inhaled, like when you're using a nebulizer treatment, sometimes in older patients that can exhibit as a systemic side effect. Anxiety, insomnia can be a problem. And obviously appetite suppressants and ADHD meds. Next slide. So unfortunately, medications replace sleep hygiene as first-line treatment only because most providers don't have enough time to devote a referral out to cognitive behavioral therapy or acupuncture or some kind of a non-pharmacologic approach. But really, most of the drugs for sleep are on the Beers list for one reason or another. And sedating antihistamines are on the list for cognitive decline. And a lot of these antihistamines are hidden in combination products like Tylenol PM, Advil PM. This isn't just Tylenol or Advil, they also have diphenhydramine in it. So figuring out exactly what they take over the counter can be really useful. Obviously, all benzos are on the Beers list for cognitive impairment, risk of falling. things like that. And all non-benzo sleepers like Zolpidem, Lunesta, Sonata are on it, and TCAs are on it as well. So are gabapentin, quetiapine, and trazodone for next time sedation and dizziness. So really all the drugs for sleep that we have available to us for the most part are on the Bayer's list. Next slide. Sedative hypnotics are harmful in seniors. There's actually research published to support that. Back in 2005, they did a meta-analysis of 24 randomized controlled trials with over 2,400 patients over age 60. And what they found is it takes fewer people to see a side effect than it takes for it to actually to show efficacy. So number needed to harm or cause a side effect or an adverse event is 6, and number needed to treat successfully is 13. So you're more likely to get a side effect than efficacy from these drugs. And side effects observed were things like drowsiness, fatigue, headache, nightmares, nausea, loss of balance, dizziness, falling, motor vehicle accidents, broken bones, and drowsiness in the AM. Next slide. A meta-analysis of risks and benefits of benzodiazepines and benzodiazepines-like drugs. Again, several studies, same reference from 2005. But what these results show is how little efficacy there is from all these medications. So in 8 studies of 601 patients, there was an increase in sleep time by less than a half an hour. In another 8 studies, that increase in sleep was a little bit over a half an hour, 34 minutes, as opposed to 25. In another study of 441 patients, the number of awakenings was decreased by less than 1. And in another cohort of studies, it was decreased again by less than 1. So if you are getting a benefit from these drugs, it's really minimal and really clinically insignificant. Do you really want to give somebody a medication with potential adverse events that increases your sleep time by half an hour or reduces awakenings by 0.6? This is an objective clinical trials. Next slide. Benzodiazepine use is costly. They looked at a VA population of over 17,000 veterans, and what they found is there were more hospital admissions and certainly more outpatient visits as a result of using these medications. So it's not cost effective to use them. Next slide. So what's wrong with the non-benzo hypnotics? When they were developed, everybody was super excited about them because finally we have something with a quick onset of effect and a short duration of action, and what could possibly go wrong? Well, it turns out since we've started using things like Ambien, there was a 220% increase in ER visits solely related to Ambien use. The risk of hip fractures was increased in patients using these medications. They were more likely to cause a fracture than benzodiazepines, and there have been reports of behaviorals while asleep similar to those seen with benzos, so amnestic kinds of symptoms. Patients wake up, they're up in the middle of the night, they make phone calls, they get into the car and start driving, and they have no recollection of doing those things the next day. Next slide. So when you look at these medications, these are the benzodiazepine-like drugs. So we're talking about Lunesta, Sonata, and Ambien. They look great on paper. Onset of effect, 30 minutes. Sonata, Lunesta, if you look carefully, the onset of effect is actually even less than 30 minutes. Half-life is short, 6 hours max. Sonata 1 hour. When Sonata getting providers, oh, you can give it twice a night. They wake up in the middle of the night because it stops working, you give them another one. Great marketing tool, right? But what happened, and look, at Ambien is available in 3 different formulations. One is just 5 or 10 milligrams, and one is these fancy formulations where a little bit is released all at once, and then the rest of it is over a longer period of time, so you don't have the awakenings throughout the night, but really they're not helpful. They don't do the right thing for the patient in terms of correcting sleep, and they're potentially dangerous. Next slide. Herbal supplements. What do we have in that arena? We have melatonin that we actually use very extensively. I think the trick with melatonin is to figure out the right dose. It could be anywhere from 1 to 10 milligrams. I've seen a few patients taking 15. So if somebody says melatonin does not work or it's partially effective, I would really encourage you to increase the dose to see if you can get maximal effect out of it. Chamomile can be helpful. It doesn't really put you to sleep, but it kind of calms you down enough so you can fall asleep if anxiety is one of the reasons why you can't sleep. So sometimes having a little chamomile before bed is a good idea. There's one thing, if you're allergic to ragweed, you might also be allergic to chamomile. So make sure you screen for that before you recommend it. And then the other thing is valerian root. It's very popular in Eastern Europe and other parts of the world, but I think it may be potentially dangerous because it is a relative of a benzodiazepine, very similar in mechanism of action to Xanax and Ativan. So probably not a great idea in older patients. Next slide. So if melatonin is only partially effective at the highest dose, you can try pharmaceutical grade melatonin agonist, which is called Rosarum. It's now, especially in the United States, it's more accepted and covered by a lot more insurance plans. It's a single strength, 8 milligrams, onset of effect is 30 minutes, half-life of the drug and the metabolite about 5 hours, so good good activity, and it might help, especially if you get partial benefit from melatonin. Next slide. Miscellaneous agents. So trazodone is an old drug that used to be an antidepressant. We didn't use it much as an antidepressant because it was just really sedating and very short acting. So you'd have to administer it multiple times at high doses. At the antidepressant dose, you get a lot of orthostatic hypotension issues with it. But in a lower dose, 25 to about 150, some patients need to go up to 200. It can be effective for sleep. And it's the only pharmaceutical agent that actually may increase delta sleep. So if you're that's one of the reasons why we use it a lot. So dizziness is a concern, and that's another reason to start slowly. If you start with 25 milligrams and work your way up gradually, you can use it without causing a fall in somebody. The dose is really variable. Some people do great on 25 and some people need 150. So work with it, titrate it up slowly at every visit, and kind of see how far you can get with this drug. It's not habit forming and there shouldn't be a tolerance. Next slide. Another drug we use for sleep, but also in someone who's got maybe anxiety or depression, is mirtazapine. It's actually more sedating at a lower dose. So the dose you want is the lower dose in the spectrum, so 7.5 milligrams. Sometimes very sensitive older adults or tiny older adults are going to be very sensitive to this drug, and they'll get a lot of early morning grogginess. In that case, I would even recommend going to 3.75 milligrams to start with, to see if that might be low enough to be effective for sleep, but at the same time not produce daytime fatigue. Next slide. Doxepin, again, an old tricyclic, and we generally don't like using tricyclic in the elderly. So in some ways, this is kind of a new kind of marketing tool to market this old medication. The dose for this drug, Silenor, is only 3 to 6 milligrams. So if you're older and you used to use Doxepin in your practice years ago, you know that the starting dose for Doxepin is at least 10 milligrams, going to 25, all the way to 150 and sometimes 300 milligrams. So 3 to 6 milligrams is a tiny dose. So that might work in someone who does not have any issues with cognition or dizziness. So because it is a tricyclic after all, but the reason you might be able to get away with it is because it's such a low dose. Doxepin generic doesn't come in 3 or 6 milligrams, so you have to end up using 10. And this brand name of a drug is fairly expensive, not covered by a lot of insurances, but that's an option. And is it effective? Not terribly. In the study that got its approval, it increased sleep time by 52 to 63 minutes over 4 weeks. So not terribly effective, but maybe an option. Next slide. So for your non-geriatric patients, you could always use an antihistamine. It's over the counter. But again, in older adults, you want to avoid it whenever possible because of cognition issues, confusion, delirium, dizziness, all kinds of problems. And again, it's hidden in a bunch of over-the-counter combinations. Next slide. So these are the two relatively brand new on the market. One is Belsorma and one is Dayvigo. Their mechanism of action is completely different from benzos and benzodiazepine-like drugs. They're orexin receptor antagonists. So they actually inhibit wakefulness as opposed to putting you to sleep. They block your ability to stay awake. So they kind of work like oh gosh, what's that drug that Michael Jackson died of? Drawing a blank. Anyway.
Fentanyl, right? Fentanyl?
No, it wasn't fentanyl. It was
propofol.
Propofol, thank you.
Yeah.
It's kind of like propofol. It just knocks you out. So obviously this is potentially really dangerous in an older patient. So Belsorma is the older one. Dayvigo just came out recently. They obviously are associated with daytime sedation, behavioral and cognitive changes. Some psychiatric symptoms have been noted from using these medications. They can cause sleep paralysis, really contraindicated in those with respiratory disease like COPD or sleep apnea. And the direction is you have to stay in bed for 7 hours and be in bed within 30 minutes of taking this medication. Obviously, that's going to be a problem in those older adults who have to pee during the night. So again, problematic with use. And the other issue is drug interactions. Both of these drugs go through the CYP450 pathway, and they will be inhibited by other by CYP inhibitors, like a lot of antibiotics, calcium channel blockers, amiodarone. A lot of antivirals go through this pathway, so they can potentially increase levels of both of these medications, causing more toxicity. And then pharmacodynamic interactions with other CNS active drugs can also produce an exacerbated effect. Next slide. So this is an interesting study. It came out in JAMA in 2019, and this compared this brand new drug, Dayvigo, with Ambien extended release. And the name of the study is a comparison of Ambien ER to Dayvigo in older patients. This is a typical study that comes out that looks at a geriatric population. Let's look at the details. The age range for this in this study was 55 and a mean age of 63. That doesn't even qualify as geriatric, okay? They had a huge exclusion criteria: concurrent COPD and sleep apnea, nocturia. How many older adults do you know that don't have nocturia? Renal impairment, again, extremely common. Psychiatric disease, how often do we see depression, anxiety in older patients? Malignancy in the past year. So all of those were exclusion criteria. They compared the correct doses, 6.25 of Ambien versus 5 milligrams of Dayvigo and 10, which may not be appropriate in older adults in the first place. And they did find that Dayvigo was better tolerated and more effective. They had a few falls, a few sleep paralysis cases, but not a huge amount. But this is with a huge exclusion criteria and a very young patient population. The study duration was only 30 days, and it was manufacturer sponsored. So this is just to give you a flavor of what's out there. So just because a study says older adults can use this safely, you have to look at the details, because this will really guide your decision-making process as to whether or not to use this drug. So obviously these results would not apply to most of the patients in our clinic at UCI. Next slide. So non-pharmacologic therapies work best. You should really spend the time to educate your patients. I've had really good success with those to utilize other disciplines. Utilize your clinical pharmacist in the clinic. Utilize your occupational therapist. They can go out to the home and do a home eval and talk about sleep hygiene. Drug use is really limited. I mean, it's only going to be so effective for this condition, so it's better not to use it. Sleep supplements may be useful, and really medications should only be used as a last resort. Any questions?
We have time for questions if anybody has any for Dr. Gurvich, or if any of our hub team would like to add anything.
Dr. Gurvich, this is Nicole. I had a question about the Rosram that you were discussing.
Mm-hmm.
So that you would use in conjunction with a melatonin supplement, is that correct?
No, instead of.
Oh, okay.
So I would start with melatonin because it's widely available and inexpensive. If you can't get full effect from melatonin, but they're getting a partial response, I would try Rosarum. So it's one or the other. Melatonin is the real thing. Rosarum is a melatonin agonist, so it acts the same way at the receptor as melatonin would.
Okay.
So I would use one or the other.
Okay, thank you.
Mm-hmm.
If you have any questions, you're more than welcome to type them in the chat as well.
Do you have an algorithm for what you like to do? So kind of the cognitive behavioral therapy, melatonin, what's kind of the pathway that you like to go for the safest for the patient and most effective? Thanks.
So that's a good question. I think sleep hygiene is first, then I would try melatonin and possibly Rosarum if melatonin is partially effective. Trazodone, it can cause orthostatic changes occasionally. So if a patient has a strong history of falling, I'm a little reluctant to use it. So that would be maybe third on the list. And if I am using it, I'm going to use it at 25 milligrams to start, wait at least a week to 2 before I make any changes. And the interesting thing to me about Trazodone is I've seen, tiny little women needing like 125 milligrams of Trazodone to work. And it takes a while to get there. And once they get there, it does work and they're very happy, but it takes a while. So, so working with it, I think, is worthwhile. If that doesn't work, then you're into an area where not terribly comfortable. Maybe a low dose doxepin if they don't have cognitive impairment. Oh, mirtazapine. If there's an underlying psych thing, then mirtazapine can be useful as well. So that's kind of my approach.
If I have a patient who's on Seroquel 50 milligrams and is able to sleep for an hour or two, do you recommend changing medications or trying to increase that medication? Thank you.
So Seroquel, yeah, I would not use Seroquel for just insomnia. If there's another reason to be on Seroquel, then by all means use it. Like if it's agitation associated with dementia, that Seroquel helps with. Seroquel can also be quite orthostatic, so I would be really concerned about going up to higher doses. Generally not recommended. And if they're only getting an hour sleep with it, is it really worth it? Sometimes patients with dementia will have night and day mixed up, and so sometimes melatonin can be helpful. So I might add melatonin to that.
Thank you.
This is Nicole again. So for the Trazodone, sorry to cut you off, Nika. For the Trazodone, you titrate up every 2 weeks is safe?
So yeah, I think every 2 weeks is safe. And some patients, you can do it a little bit quicker if they're younger and kind of more functional, but I think 2 weeks is reasonable. Because it works quickly. You're using it for its side effect. Sedation is one of the side effects of Trazodone. That's why you use it. So 2 weeks should be fine.
Yeah, sometimes a while for you to notice.
No, it should work. It should work quickly.
Okay, great.
Thanks, Tanya. I didn't realize that occupational therapists worked on sleep. Is it specific occupational therapists or,
I think they all get training. So I work with an occupational therapist at USC, And this is what she does. She does an evaluation for us for our assessment team. And one of the things she does is that she talks about sleep hygiene. So I think they all get training in it. The occupational therapists who work at UCI actually do more of a PT assessment than an OT assessment. I don't know why that is. But a classic OT training includes sleep hygiene. But it could be a nurse in your practice. A nurse could learn it, an MA could learn it. It's not rocket science. You could all do it. I think physicians just don't have time to spend a lot with a patient for that long to kind of go through everything. When I have my pharmacy students there, I send my pharmacy students and they talk to them about sleep hygiene. It's kind of fun. You basically get a 24-hour recall of what they're doing, starting from when they have to have a regular time to go to bed, and how many naps do they take? Do they look at the alarm clock when it's 2 o'clock in the morning? How much alcohol they drink. So get their 24-hour routine, and you can always find something to do differently to improve sleep.
Well, thank you so much, everyone. I know we have a few questions in the chat. Dr. Gurwitch, I don't know if you have a chance to answer those in the chat or we can answer them later, but I do want to make sure we have time for our case presentation. So we're going to go ahead and move on to that. This case is going to be presented by NP Nicole Vidal, who works at Share Ourselves Costa Mesa. And NP Vidal will go ahead and give us a quick summary of her de-identified patient case. And the patient will refer to as patient 219. So give me 1 second as I go ahead and pull this up. 1 second. Okay, Nicole, you can go ahead and give us a quick summary of your patient.
I'm on the
Can you hear us?
today, so.
Okay.
Yeah, can you hear me?
Yes, we can hear you. Sorry, I know it looks like you're driving. I hope you're going to be safe.
I'm in a mobile clinic today, so.
Okay.
I pulled over. But anyways, so I have this 65-year-old male who came in to see me as a new patient to me. He has a long-standing history of what he described as insomnia that he was taking Ambien for 5 years. At his last appointment in the office, the provider had told him that he needed to see psychiatry, and they cut his dose from 10 milligrams to 5. And he had run out of that a couple months prior to me seeing him. So basically came in, continuing with insomnia. He wanted me to refill his Ambien at the 10 milligrams. That he does have a history of anxiety as well. And most of his issue is with falling asleep. But once he falls asleep, he's able to sleep pretty soundly through the night. So the anxiety is keeping him up. He can't pinpoint anything specifically that is causing the anxiety, just kind of a generalized worry. Not seeing a psychiatrist, not in therapy, not in any psychiatric medications. And so basically my approach was counseling him on why we don't use Ambien long-term in patients, especially as we get older, and discussing that maybe addressing the underlying anxiety would help address the insomnia instead of just prescribing him a sleep pill. I did also refer him back to psychiatry. I him time only to see if that might help mitigate some of the anxiety and get him to go to sleep. And some of his other symptoms, history. He has BPH with LUTs. That's currently well controlled, so he's not having to get up throughout the night to pee. Hypertension's well controlled. He was told he needed a sleep referral because he possibly had sleep apnea Personally, he has a BMI of 25 and no other real risk factors, so I wasn't convinced that sleep apnea was his problem. Has tried melatonin in the past with no improvement. I'm not really sure on what dosage he was on. And then his past meds, Lipitor, Cardura, and Zolpidem. I do see the Zolpidem and started him on the Boost Par. I actually just saw him again this last week. He said the Boost Par wasn't really helping. It had been, I think, 3 weeks since he started it. No, 18 days, sorry. 18 days since he started the Boost Par. He hadn't noticed an effect, but he stayed on it at the advice of his sister, who he says is a physician. So we kind of talked a little bit more. I did increase his Boost Par to 10 at night this past visit to see if that would help, but I guess my question really is, what is your approach really to having that discussion with patients about why we don't use Ambien long term, and dealing with insomnia due to like an underlying other diagnosis like anxiety or combo anxiety depression?
Who wants to take that?
Yeah, and our all of you, basically this is a group effort, so any of our registrants as well that are on the line, if you have anything to add, please go ahead.
So I can just jump in with the drug component, and then you guys can discuss everything else. So just listening to you, I would want to know how much trazodone was actually tried, and what, because again, it's a dosing range. I would want to know how much melatonin was tried. I think starting Buspar is a great idea because it sounds like his underlying issue is anxiety. I would encourage you to keep going up because the maximum dose of Buspar is 60 milligrams. This guy is only 65 years old, so 10 milligrams may not be enough for him. So going up on that is a great idea. The other option would be to do mirtazapine if you think there's maybe a depressive component to his anxiety as well. So that might be something to try. As far as telling him the dangers of Ambien, I just like the other thing that a lot of people with the insomnia issues have who are taking benzos or Z drugs is that they don't remember sleeping. They have no sleep memory. They kind of fall off into a hole and then wake up when the alarm goes off or something else wakes them up. So the quality of sleep they're getting isn't great. So I kind of focus on that. And when I tell them, do you remember that you slept yesterday? They say no, because they don't have sleep memory. And so that sometimes opens their eyes up a little bit and they want to try something different.
Yeah, so I was thinking of starting him on a low dose mirtazapine. But the 60 milligrams of Buspar, can you take that all in one dosing, or does that have to be split up throughout the day?
So the full dose of Buspar is 60 milligrams a day. So that's 20 TID. It can actually be dosed during the day too. So you could go up to 20 at bedtime.
Okay.
That would be okay. Or you could spread it out a little bit if he's anxious during the day.
Okay.
And again, he's a young older adult, so I'm a little less worried about orthostatic changes and dizziness and stuff like that.
Yeah, he's fairly physically active, in good shape, physically healthy, independent. So he's not frail or at really high risk for falls or injuries, but.
Thanks, Nicole. I'm wondering about his alcohol consumption, and also what does he do for his anxiety? Does he exercise? Does he meditate? What does he do?
So he says no alcohol use. Exercises regularly on a daily basis. He was cycling like 13 miles a day for exercise. But not really anything else as far as his anxiety. He said he doesn't really think about it much, but he knows he has it. So he kind of just really doesn't address it at all.
Would he be open to therapy for the anxiety?
Yeah, I did talk to him about therapy. He said he doesn't think it's that big of a deal, and so that's why he's never really pursued going to see a therapist, and that he's just dealt with it. But I tried to explain to him he's not obviously dealing with it very well if he can't sleep because of it. So, yeah, I think a lot of it's a little bit of ego too. But yeah, I'll probably try to push either therapy. I did tell him about the CBTI app to use as far as doing something at home for himself. But I don't know if Dr. Gervich maybe or one of you other doctors on the line or any member have any like really good resource you use as far as like the sleep hygiene stuff you can go through, because I know the basics, but I don't feel very comfortable or confident having a deep conversation with people about their sleep hygiene.
So I know I have sent some of my patients for the CBTI. That's a cognitive behavioral therapy for insomnia, and it helped. Yeah, in some patients who are really interested in quitting benzos or other medication and want to do more, sleep hygiene. So through the psychotherapist, it really helps.
Okay. I know our behavioral health access is a little rough, so I try to do whatever I can in my clinic and in my visit to the best that I can.
So years
know.
ago,
Yeah, sorry, go ahead.
years ago, I learned about sleep hygiene first from prescriber's letter. It's a reference that there's a pharmacist letter and prescriber's letter. One is geared for pharmacists, one's for primary care providers, and it's got a really good detailed document on sleep hygiene.
Oh, okay, thank you.
Nicole, this is Sarah Campbell, nurse practitioner here at UCI. One of the things I've done is, and this sounds really silly, but I've gone to UpToDate, and there's a table. They have figures and tables for sleep hygiene and stimulus control, and I literally copied and pasted them into a table in Word, and I keep them on my desktop, and I will use them as a handout to just have a patient quickly circle some of the things they do or don't do. So I'll have my MA hand that out sometimes while I'm doing something else. Maybe I'm charting or I'm getting tests ready or I'm ordering some things. So sometimes I'll just have the patient almost like I would like a GAD-7 or a PHQ-9. Yeah. I'll have them kind of sit down and circle things that they might or might not do before bed to see, it's kind of as a time saver. So I just literally cut and paste from UpToDate those tables into a Word document. And I just made my own document on my desktop. I saved it to my desktop so I can just print it out at any time.
That's a great idea. Thank you.
Mm-hmm. One of the other things I noticed, and this is something you might just ask him, I noticed that he has tinnitus, and sometimes that can be very distracting at nighttime. And so that might be something to address. I know that I've had patients that they don't know that this is what's bothering them so much, but it might be something to investigate with regards to a referral to an audiologist, or because I know that there is some technology now with hearing aids. If it's related to high frequency hearing loss or hearing loss, they have hearing aids now that will distract or provide another stimulus to decrease the brain's sensitivity to tinnitus. So that's something to investigate. And I know that at nighttime, as patients are trying to fall asleep, tinnitus can be really bothersome and distracting. So that may be something that's affecting his sleep as well.
Yeah, that's a good point. I don't think we discussed that very much.
His thyroid function is normal?
Yeah. I get the impression from him that he's just a very high energy person. He's got he talks really fast and loud and rambles. So I think a lot of it is cognitive, but
Does he exercise?
Yeah, he cycles every day.
Okay, does anybody have anything else to add or ask?
I just learned one thing from Dr. Sehgal during my fellowship. She always recommend like warm milk with honey, you know. So that's also something if he's not lactose intolerant.
There's you can actually pull a list of L-tryptophan rich foods off the internet pretty quickly and hand that to patients. That's a great idea.
Oh, okay.
Like a slice of turkey or a glass of warm milk, or I think cherries are also really good. I don't remember if they're high in melatonin or L-tryptophan, but cherries put people to sleep.
Okay. Nicole, do you have any other questions, or were we able to answer your questions for you?
No, that was very helpful. Thank you.
Okay, wonderful. We have just a few more minutes. I'm going to go back to the PowerPoint. Give me 1 second, please.
Oh, actually, I just have a question, like a med question while you're doing that.
Sure, go ahead.
So when I looked up using BoostPAR and mirtazapine combined, it like warned about the serotonin.
Yeah. So they're both serotonergic drugs. Serotonin syndrome itself is a relatively rare occurrence. I think 1 in every 200,000 to 300,000 patients you see it, and it's very much dose related. So you should worry about it in theory, but if you're using both drugs at low doses, it's much more unlikely to happen. So for sleep, you're only going to use mirtazapine at 7.5 milligrams, maybe. That's low dose. BoostPAR, you probably won't get to the full dose of 60. So it's just managing the doses that I think limits the risk of serotonin syndrome. But I mean, in theory, is it possible? Yes. Do you want to monitor the patient carefully? Yes. So if they become more anxious after you've started those 2 drugs, then that could be a sign of the development of it, or some,
Did you max out the BoostPAR first, or like to at least 20?
What was that?
Would you max out the BoostPAR night dose to like 20 before you added in the mirtazapine?
I think if he's getting some benefit from the BoostPAR, then I would maybe do that first. But if sleep is sort of a more urgent problem, you could start the mirtazapine. Just depends on the patient. BoostPAR it takes a while to kick in. It's kind of like an SSRI. So it takes 4 to 6 weeks to see the full effect of whatever you're doing. BoostPAR is like 20 years old. When it first came out, nobody wanted to use it because everybody's used to Xanax and Ativan that works after a single dose. So people needed to be on BoostPAR for a month before they saw benefit. Nobody wanted to do that. Now we're using it more because we now know how to use it right, and people are more accustomed to medications like this taking longer to work.
So I have a question regarding, like, some patients are on sertraline or other SSRIs. So is it safe to add trazodone again, because, for the, serotonergic side effects? So what should we, select another medication rather than trazodone?
So I think overall it is safe. Like, we have a lot of patients on both. I think the key is to keep the dose as low as possible. So like having somebody be on, I don't know, like 50 of Zoloft, for example, sertraline, and starting at 25 of trazodone, that's both of those are low doses. So I don't think you're going to see serotonin syndrome in 90% of patients. The dose is low. Remember, trazodone therapeutic doses for depression is 200 to 600 milligrams. So we're using a tiny dose. Even at 150, we're using a low dose trazodone. So you should be cautious, but I think you can go ahead and try it if that makes sense.
Okay, thank you.
Thank you so much, Nicole, for submitting your case. Really appreciate it. Just to let you all know, if you do want CME credits, please make sure that you do fill out the form that we'll send out in our next email. And we always appreciate your evaluations at the end as well. So you'll receive that link as well. Our upcoming session is in 2 weeks, and it will be focusing on effects of depression on mobility. And we are looking for cases. I don't know if anybody on the line already has a patient they're thinking about when think of this topic. We'd love for you to submit your case to us. And that is a part of our echoes. So we will be sending the templates for you. Again, it can be a complicated case. It could be quite a simple case. So please do submit your cases as well. If we have any volunteers right now, you can also speak up or type in the chat and we'll reach out to you as well. Does anybody have any last minute questions before we end our session? Okay, thank you all so much for, oh, let's see, we have something in the chat. No, just thank you. So I think we'll go ahead and end today's session, and we'll see you on February 9th.